Thanks a lot. Bonjour tout le monde. My English is probably not as bad as your French, but I think maybe because you were provocative, I misunderstood a few things, so I will ask. But very interesting report for sure. But I did appreciate the second part with your personal comments much more than the first part. Let me say why. Because as you said, we knew a lot of what you, even though it's always nice to have this on nice charts and figures, I would say that in a way we knew, or we had evidence for many of these differences between the States and other countries. So I was surprised by some of your personal comments. I will mention that, so you might, it's not specifically a question, but I think I can formulate it in a question. But, and then I have I want your general impression about the impact of the report. Because as you said, no more research, we need some action. What actions you think, what are your hopes of having some movement created by the report? Let me say why I'm asking this, because I would argue, I don't have any data for that, but I would argue that with all these countries, and mainly I'm thinking about Canada, the differences between Canada or other social democratic countries makes the difference between the health. So the health of a country is not driven by health analysis, health epidemiology, or health indicators. So now that you do have a lot of health indicators, do you think that this could be an impulse? I would argue not at all, because in Canada or elsewhere, the difference is not coming from a specific thoughts on our health. It's just democracy, other values in society, like the way you just concluded about the fact that it's not public health or it's not a biomedical view that change all that. It's social values, probably. You said there's no causal relationship between what we do observe when we measure health indicators. So I don't know if I'm clear, but because I don't think that in all these other countries, having better indicators, that never came from some analysis of the health differences. So I would ask, do you think that your result can have such an impact? One thing. And the other thing, you mentioned that media coverage was quite important of your report. What are now the public reactions, or is there any interest or movement, social movement, saying that, well, we are investing a lot in our health sector, maybe we should change that? I would argue not. After such a report, I did release some reports in the last years, and well, the first one was released while the Pope died 6 or 7 years ago, so it was not covered at all. So there's all sort of other differences that are more important than the health report. So that was a bad timing for me. Anyway, so I would ask, what do you think could be the impact with your report? And then some surprise, because in your personal comments, if I understood you well, you mentioned that you don't believe in social determinants. I'd like to hear a little bit more about that. You didn't want to go into that sector, but in the room here, you probably have a lot of people who want to understand more about that. And then the final one, what is it? Question. Oh, okay. You mentioned that we assume that the relationship we see between more inequitable societies and health is causal. We don't have any proof of that. What sort of proof do you need for that? I don't know if it's my training or the experience of living here in Quebec, but as you mentioned, we don't need more research on this aspect, even though I'm sorry for those who are doing a lot of research on this. But we need more actions, and what shall we do, us in public health, if that is the truth? So that is the important thing, because since we've been discussing these things in here, in the province of Quebec, or in Canada generally, we always ask ourselves in public health, what is my impact on that? Just mentioning it, just producing report, what can I do? I think there's a lot to do, but your question was just sent like that, and you didn't mention any answer. So those are comments and also questions. I don't know if that's too much, Louise, for the...
First, thank you very much for your presentation. I'm going to speak in French because you do have a translator with you. So, and I want to, kind of speaking all together, and so you might have questions in French and in English. Premièrement, je dois mentionner que j'étais très content de voir une étude comparative. On en a eu beaucoup, puis Alain a mentionné, on en a vu, mais d'avoir une étude qui nous permet de voir les États-Unis dans tous les aspects de leur santé qui nous sont traduits. Je n'ai pas pu lire tout le rapport, mais j'ai eu accès à un résumé, j'ai eu accès aux diapositives, et c'était fort intéressant, je pense que c'est extrêmement instructif, donc je ne vais pas rentrer là-dedans. Une des choses qui me frappe, et ça va être peut-être un peu en désordre, parce qu'il y avait Michael Marmot qui était un des membres du comité. Et on voit le lien entre ce que Michael Marmot aussi a fait dans plusieurs pays. Il n'était pas membre du comité. C'était Mac. OK. So, c'était Mac, sorry. But on peut voir l'influence là sur les déterminants sociaux de la santé. Et j'étais peut-être un peu surpris que dans la présentation, on ne mentionne pas si directement que ça le fait que ce qui compte, c'est moins le revenu national brut, donc le GDP, que le fairness of chances, comme on peut dire, ou la distribution de la richesse. Puis c'est une question à vous. Comment est-ce que vous voyez cette notion de distribution de la richesse dans les résultats de santé? Alors que c'est clairement sous-jacent dans tout ce qui est dans le rapport. Et c'est très, très important. La deuxième, c'est aussi une question qui n'est pas simple, on n'est pas capable de la répondre facilement. C'est quand on remonte aux causes des causes, on arrive aux déterminants sociaux, ou ce qu'on appelle les contextual factors. Moi, je ne vais pas rentrer dans trop de choses, mais pour moi, on peut l'appeler sémantiquement différemment, mais on se retrouve là-dessus. Et là, on se retrouve dans un terrain où est-ce qu'on doit être capable de travailler avec des gens qui ont des valeurs, des visions, des priorités, des sources de financement différentes des nôtres et qu'on doit mobiliser ensemble. Et ça, c'est extrêmement difficile à mettre tous ces facteurs-là ensemble et de dire on acte, on bouge, on fait un changement, on s'entend. Et ça, donc, comment est-ce qu'on peut faire pour passer d'une analyse qui nous touche sur les facteurs contextuels à une mobilisation des gens? Puis quand vous avez parlé de la Scandinavie, en fait, c'est impressionnant de voir les valeurs qui sont là depuis très longtemps, qui mobilisent leurs actions. La troisième question, c'est, vous avez touché la santé, vous avez dit, le secteur de la santé est assez bien, dans le fond, peut-être qu'on devrait le regarder comme ça. On a une question de fond, le coût de la santé augmente continuellement, et puis on peut le voir ça comme un enjeu, puis on peut le voir aussi comme une richesse collective, sauf si cet investissement-là vient à l'encontre de l'investissement dans les facteurs contextuels, dans les déterminants sociaux. Et là, c'est ça qu'on a. Dans le fond, on a le secteur service de récupération de la santé qui nous amène à prendre de plus en plus une part importante dans les facteurs sociaux, environnementaux, de développement social, où est-ce que là, on a de la misère à investir. Donc, comment est-ce qu'on fait cette balance-là? Est-ce que, dans le fond, ça ne devient pas un problème? De ce niveau d'investissement-là comme une nuisance pour investir dans ce qui crée de la santé, dans les facteurs en amont. Puis la dernière chose pour arrêter, c'est, merci Louise, c'est la question de crack down the system. Dans le fond, c'est une invitation que vous faites à vous, qu'on fait à nous, c'est êtes-vous capable d'aller à l'intérieur d'un pays pour voir les facteurs qui font la différence? Puis en fait, c'est ça qu'on a commencé à faire au Québec, c'est ça qu'on a commencé à faire à Montréal. Puis les rapports du directeur ont fait un effort très important pour disséquer. Puis je donne 3 exemples que vous connaissez. Sur le tabac, la table de répartition du tabagisme, puis bon, Marie est avec nous, l'équipe tabac est là. Le dépistage du cancer du sein, pour lequel on voit toutes les disparités, ça nous permet d'aller agir pour voir les facteurs sociaux, culturels, économiques. Et la prévention des traumatismes. Hier, on présentait à la Ville de Montréal pour prévenir les traumatismes chez les piétons, et on voit que encore toute cette carte-là est liée très fortement aux facteurs contextuels, pour reprendre ce facteur-là. Donc, on fait des efforts pour ça, mais on est loin d'avoir réduit les disparités. Malgré tout, on s'est rendu compte que les disparités se maintiennent à peu près, sont très élevées, et qu'on a encore, entre différents secteurs, jusqu'à 10 années d'espérance de vie de bonne santé. Fait que malgré le fait qu'on fait ça, on a fait probablement pas assez, très difficile, mais on a encore des disparités sur l'espérance de vie, puis l'espérance de vie en bonne santé qui se maintiennent. Donc, je pense que vous nous ouvrez une voie, qu'on a commencé à rentrer dedans, mais qu'on est encore loin d'avoir atteint nos résultats. Donc, merci beaucoup, puis je pense que ça va être certainement très instructif pour tout le monde de suivre ce que vous faites.
Well, just one quick answer to one part, of this causality interesting when you talk about changing the factors that produce bad health. What if why shouldn't we see if we look backwards and we reduce, and you reduce health outcomes, then shouldn't the social factors go up at the other end? If the social factors are causal, then they should improve when health improves, if the cause works in both directions. Just something to think about. Let me take the first questions. Media coverage, just to shortly relate back to the study. It was, first off, the study was, the report was postponed for a while because we didn't want to release it during the elections. It was actually done just slightly before the elections, the last election, and could have been released then, but it was not, because for various reasons that I can't even discuss, but it was not. So it was we waited until the beginning of the new year, so it came out in 2013, in January. And the first release of it was to send the Senate, and a lot of the slides I put up and what I talked about was the Senate briefing. And so that engendered quite a bit of interest. What happened in the media was relatively good at first. The NAS keeps track of all the media blurbs about it and things that appear in the newspapers. And there was pretty good newspaper coverage, but in some ways kind of expected. The concentration often went to the health services part and not to the social factors part. And and it kind of, I think by now it's kind of lost in the media. One of the things the report did say is that it called for a national discussion and asked that the NIH and the various parts of government actually create a national discussion. And it had recommendations, policy recommendations and research recommendations. My suspicion, it's just a guess, but my suspicion is the research recommendations may be taken up because they were very specific to NIH and CDC about what they should do. And that's something that those agencies can then take to Congress and say, we want money for this to work in this area because you have this report that says that there should be work in this area. So the research impact, I think, will be pretty good. As to the public impact, that's much harder to judge, and I just don't have a feeling that it's had the part. There are just too many other things going on. Most of these, it seems to me, just speaking personally, many of these health messages that come out, they have a very short half-life. They just last for a few days, and they may make an appearance on the news, and then after a few days they sort of disappear. And I think that probably is true of this report and other reports that have been put out that would engender any kind of reaction. There wasn't, maybe not to my surprise, there was very little media literature that came out, and other than pointing out the basic title of the book, there was very little that said, that we're really in a bad situation in the U.S. We must do something about it. There wasn't that approach. The, just a quick question on social determinants. I actually believe in social factors in health and illness. I believe there is a relationship between these social elements and health outcomes. But I don't, but the problem I have with social determinants is the word determinants. It's too powerful. The more you look at the great amount of evidence that there is, the weaker it becomes. In terms of any kind of solid proof, and I think we should leave proof to I guess to rocket scientists or something like that, because basically the proof, the solid proof of any of these determinants becomes, the so-called social determinants becomes very difficult. There is almost always causality implied, and there are almost always relationships that are seen. But when you look across that big spectrum, if you want to see relationships between social policy and outcomes, they're there. The relationships will show. If you want to see the relationship between smoking and health outcomes, they'll show. But when you try to pin it down to direct deterministic causality, it's very difficult. Tobacco smoking might be one of the most clear causal relationships to a disease outcome. But all these others are very weak outcomes. They're very weak correlations. And one of the reasons they're weak is because there are thousands of variables involved. And there are another thousand variables that are thousands of variables, there are other thousands of variables that are never considered. You know, that's the problem when you're trying to look at something that seemingly occurs at the systems level. And if the problems are occurring because the United States has a strong sense of individualism, where does that come from? You look at patterns of migration to the U.S., who went there, when they went there. You can dig down in this and really get into the weeds very easily. But the further you dig down, the less you're going to be able to connect it to a health outcome over here. The second problem is that and this part of the second question about investment in health keeps rising. Actually, there's not much investment in health. There's investment in disease outcomes. And that's really quite a different pattern. What we're seeing here in this report, to me, is, and the same thing in the social determinants of health report, the Marmot report, is we're seeing outcomes that are related to both health and disease, and we interpret the disease ones as somehow related to health. But we're not always using the same outcome variable. So it's really, the more complex it gets, the less you can be deterministic. You have to be stochastic and probabilistic. And the word determine is not a probabilistic word. And I know it's a word that people like because it makes you feel more comfortable that something can be really shown to be true. Unfortunately, that's not the way that the science of this area seems to work. From my perspective, what you have are a lot of relationships that look, from an argument point of view, from an assertion point of view, make perfect sense. Do I believe there are social factors that interplay and cause the health thing? Do I believe there's a relationship between the American value of individualism and this outcome? Yes. Between America's religious views and the role of religion in America and this. When we looked at that in Chapter 8, we looked at those values. But to make a connection between, say, conservative evangelistic Christianity and a disease outcome is not in the data. You won't find it. You won't find it in any data that's available, and you won't find it in a causal framework. But do I think that relationship exists? Yes, of course I think it exists. But I can't make that argument as proof. I can't say that's a determination. In regard to the distribution of wealth in the U.S., we did look at distribution of wealth versus, we did look both at GNP and we did look at per capita. There are other tables in the report that look at GNP as well. So they're both relevant, but you'll get pretty much the same distribution if you look at GNP as well. The distribution of wealth did come up in the report and calculating, when you look at the Gini coefficients and these kinds of things, that was all looked at. But what you really see in that one slide that I don't have up right now, but the one slide where you looked at social services, the amount of per capita income, and that could be GNP too, and social services versus health services, the US ranks very low in the amount of money they spend on social services. And so I think that ratio is very important. And if I were going to explore this data in more detail, looking at the economic argument, that's where I would look. I'd look there. All of this argues to me that we don't need to spend any more money on health. We need to, or whatever we mean by that, or disease. What we need to spend the money on is the support services that are across the board in other areas. That's what this data says to me. So there is a financial argument, I think, for that. But just sort of in conclusion, conclusion to those statements that were made, I think we have a problem that we expect the government to solve this problem, when in fact, to a great extent, it's the government that's created the problem. You know, and so you're sort of asking the wrong area to actually make these investments and changes. I mean, I think that there is perhaps a case for the use of NGOs, the private sector, and other areas. But if you want to look at the relationship between all these variables, you do wind up thinking, well, if it's the whole social system that is the thing that is contributing to these differences, you need a whole of government solution. That's not going to come out of people who work for the government. You know, there are lots of things I can say now, for example, that I couldn't say when I was in government, because it's not our remit. You know, if you work in government, you work, and particularly in the U.S., which was the largest country. That's one other final thing I'd say. Was the largest country of all these comparative countries, and it's got the biggest governmental system of anywhere, and it's highly siloed. And if all the dimensions that you need to address are in other silos, and you're not in those silos, or you're not connected to them, it's very difficult to make any changes.
Merci beaucoup. On va avoir le temps pour quelques questions, s'il y a des gens qui